Okay, so we're just going to get right into it. So my name is Kat McDonough. For those I haven't met yet, I'm a PGY3 in emergency medicine. Can everyone hear me? We're good? Okay. As part of the Social EM lecture series today, I'm going to be talking about mass incarceration as a public health crisis in this country. Last year for my Social EM lecture, I talked about redlining, and I just think it's really important to increase education, awareness of different systems and policies that have contributed to health disparities for vulnerable populations in our country. In the ED, every single day, we interact with people who are incarcerated or formerly incarcerated, who are part of the criminal justice system, whether on probation or parole, and they're at risk of not only significant violence and other problems in incarceration, but also multiple health disparities and lack of access to adequate medical care. So I think it's important that we know what our patients that we deal with every day who are coming to seek care from us are dealing with as both in part of the incarceration system, but as well as afterwards. So first, we're going to talk about some statistics. Then we're going to go into a brief overview of the history of mass incarceration and what has driven it over the years. We'll touch on the health disparities that incarcerated populations disproportionately face. We'll look at what healthcare inside prison does and doesn't look like. We'll just briefly talk about the effects of incarceration on community health as a whole, and then we'll try to bring it back to us and make it more relatable and talk about ways that we can be more conscious of improving the health of incarcerated populations and what we can do in the ED. So it's probably no surprise to anyone here that we have a huge mass incarceration problem in this country. The US locks up more people per capita than any country in the world. And depending on the source, it's anywhere from 500 something to 600 something people per 100,000 residents are locked up at any given time. This comes out to 2 million prisoners at any given time. And that's not including people on probation and parole. When we include those people as part of the larger criminal justice system, it's over 5.5 million people in the criminal justice system. The US is only 5% of the world's population, but we hold 20% of the world's incarcerated people. So we have a big problem here. This graph compares the United States and New York State to other NATO countries. We far exceed other countries in terms of our incarceration rates, but also many of our states also have higher rates of incarceration than majority of countries around the world. Comparatively, New York State actually falls kind of middle to lower compared to other states' incarceration rates. Louisiana has the highest incarceration rate in the country, but most of our states in the US still far exceed the incarceration rate of most countries in the world. When we're talking about where people are locked up, the majority are actually locked up in state prisons, followed by local jails, and then followed by federal prisons and jails. It's important to note that people in local jails, the majority of them are not convicted, meaning that they have not yet been convicted of a crime and they're awaiting trial, but they're still incarcerated. Also, just important to note is that immigration detention is a significant issue in this country as well. That's another huge topic that unfortunately is a little bit beyond the scope of what I'm going to be talking about today. But they, in immigration detention centers, they deal with a lot of the same health disparities and lack of access to care. It's no surprise, and a big topic of this presentation is going to be the racial and ethnic disparities in who's incarcerated in this country. Black Americans only comprise 14% of the US population and are incarcerated at 5 times the rate of white Americans. Latinos are also far overrepresented in our incarceration system. So zooming into New York State itself, at any given time, there's about 60,000 people in New York State locked up behind bars. Again, following national trends, most are in state prisons, followed by local jails, followed by federal prisons. Expanding that to people that are on probation and parole, we have a total of 165,000 New York residents who are within the criminal justice system, most of which are on probation or parole, so who have formerly been incarcerated. The New York trends of racial disparities and who is locked up follows the same national trends. So again, in New York, 14% of New York residents are Black, and they are way overrepresented at almost 50% of the state and federal prison population in New York State. Comparatively, white people a lot more of New York residents and are not being incarcerated at the same rates. If we focus in on New York City, we see that the highest incarceration rates per neighborhood come from neighborhoods that are historically and predominantly Black, such as Bed-Stuy, Brownsville, East New York, very common populations that we serve at our hospitals. Also Harlem, the Bronx. So again, just disproportionate rates. We really didn't start to see a significant increase in incarceration to the point where we have this mass incarceration crisis until the late 1970s and 1980s. State policy really drives who's in state prisons, which really drives the mass incarceration crisis that we see today. And you can see here that, things were relatively stagnant up until the 1970s and 80s. And then in every single state, there was really a significant acceleration in who was being criminalized and locked up. And so that's what we are going to look at next. So the United States has long relied on police, courts, jails, and prisons for social and public health concerns. It has also largely been used to marginalize and penalize people of color over time. So we are going to review key moments in US history that show this and have contributed to the mass incarceration problem we see today. So the forces of mass incarceration are deeply rooted in centuries of enslavement of people of African descent. And it's absolutely connected to the exploitation of labor, racial discrimination, and the criminalization of mental health disorders and substance use disorders. We see this all really start at the end of the Civil War, when the 13th Amendment to the US Constitution was ratified. And it stated that slavery and involuntary servitude are prohibited except for as punishment for crime. So this became known as the loophole or punishment clause, and really paved the way for Southern states to use a number of legal tactics to continue white control over Black people and exploit their labor. There were two things happening at the time. White people, there was anxieties about newly freed Black people, and there was also an economic depression resulting from the loss of free slave labor. And so the Southern states really used a number of tactics to both pacify the public sphere and bolster the depressed economy. One of these was something called the Black Codes, which were enacted immediately at the end of the Civil War when slavery was prohibited. And these were laws that were passed across Southern states to criminalize Black people for minor or everyday activities, or minor offenses or everyday activities. These could be things such as walking without purpose, walking at night, staying out after curfew, having weapons, not carrying proof of employment, very minor things to normal everyday activities that were targeting Black people and causing widespread prosecution and incarceration of freed African Americans, and really paved the way for the Jim Crow South that came a bit later. Also, something that was developed at this time, right at the end of the Civil War, was convict leasing. So states who had incarcerated persons would lease out incarcerated people to private companies for a fee. So this operated through an external supervision model in which the states would literally send incarcerated people to live on and work for private companies. The private companies would pay the state a fee for their free labor, and then the state would not have to use money to build prisons. This was essential legal slavery through the punishment clause. Another brutal form was something called chain gangs. So convict leasing was prohibited in the 1920s, and instead something called chain gangs came into play, whereas state prison authorities used incarcerated individuals to work on public works, such as building roads, agriculture, clearing land. So instead of working for private companies, they worked for public works, but they were forced to do this labor and oftentimes chained together. The next big moment for mass incarceration came in the 1960s. So in the 1960s, we saw deinstitutionalization of people with mental illness. Prior to this period, people with mental illness were largely locked away in state asylums, state psych hospitals, with pretty much no option to care for themselves or seek care outside of there for their mental health problems. We also saw around this time an advancement in psychotropic meds and adoption of Medicaid in 1965. So President JFK at the time in 1963 signed the Community Mental Health Act. This act was intended through federal financing to incentivize local communities to expand community health centers, close state asylums, and really allow people to live at home and seek their mental health care through a vast network of community health centers. This was effective in closing state asylums. Over a few decades, 90% of the state psych hospitals closed. However, the creation of a vast network of community mental health centers really fell short. Only half of those centers were ever actually built. They were not fully funded, and drastic cuts were made to the remaining community health centers through the Reagan administration that followed. So jails and prisons essentially became de facto institutions for mental illness and substance use disorder. The 1960s also saw a wave of violence and riots in urban centers in response to police violence, residential segregation, racial discrimination. The civil rights movement, of course, was occurring at this time as well. And while Black Americans achieved some measures of social and political freedoms through the civil rights movement, politicians really emerged a law and order rhetoric with racial undertones, essentially linking the violence that was happening in urban centers to being a racial problem. In 1965, President Lyndon Johnson declared a war on crime, and public perception of crime really became linked to with race in the public's consciousness. And in 1965, he signed into law the Law Enforcement Assistance Act, which was the first major federal crime bill that made funds available to states, localities, and private organizations to improve methods of law enforcement, court administration, and prison operation. A recession followed in the 1970s, in which there was a loss of jobs in urban centers. There was white flight, meaning that white, more middle class and upper class families left urban centers to move to the suburbs, further concentrating poor Black communities in neighborhoods and urban centers. This led to disinvestment, decay, decline in employment opportunities for Black people in these urban centers, and really just a decline in the quality of life. In its place, an emergence of drug markets and other illicit markets emerged. This is when the law and order rhetoric became really a war on drugs rhetoric, which was officially declared by President Nixon in 1971. Nixon declared a, quote, war on drugs in which, quote, America's public enemy #1 is drug abuse. This really marked a new era of American drug policy, increasing penalties, enforcement, and incarceration for drug offenders. The DEA was also created at this time in 1973. Specific to New York in 1973, the Rockefeller drug laws, or what became known as that, were signed into law, which really created new harsh sentences for drug offenses, including really severe mandatory minimums. The 1980s, because of what was happening in the cities and the emergence of drug markets, really was struggling with a crack epidemic. The war on drugs previously under Nixon was actually a relatively small component of the federal law enforcement efforts until Ronald Reagan became president in 1981. Reagan greatly expanded the reach of the drug war, and his focus on criminal punishment over treatment led to a massive increase in incarcerations for nonviolent drug offenders. There were 50,000 nonviolent drug offenders in prison systems in 1980, and in 1997, there were 400,000. There was a lot of time, obviously, anxiety about the crack epidemic in cities, and just public nervousness over it. And so this really helped support Reagan's war on drugs, and got a lot of public support for it actually at the time. In 1986, Reagan signed the Anti-Drug Abuse Act, which allocated $1.7 billion to the war on drugs, and established a series of harsh laws and mandatory minimum prison sentences for various drug offenses. Most notably, the law created a quantity-based 100-to-1 disparity between federal crack cocaine and powder cocaine offenses. So powder cocaine, more expensive than crack cocaine. Crack cocaine was predominantly used by Black Americans, and powder cocaine was predominantly used by white Americans. This law created a 100-to-1 ratio, meaning that 5 grams of crack cocaine got you the same 5-year prison sentence as 500 grams of powder cocaine. So in 1986, before the law was passed, the average federal drug sentence for African Americans was 11% higher than for whites. But within 4 years, due to this law, this average was 49% higher. So we see this graph here shows, 1970 was when Nixon declared a war on drugs, and everything really just climbed from there, particularly in the 80s when Reagan took over. If you break this down, this is really driven by a significant disproportionate incarceration of Black Americans for drug arrests, whereas white American drug arrests barely increased. There's a misconception that, oh, this was just because Black people were using more drugs. That's actually not true at all. Multiple studies over time have shown that Black and white people use drugs at the same rates. However, Black people are like 6.5 times as likely to be incarcerated for drug-related crimes. So the 1990s following that, there's the historic 1994 crime bill signed in by President Clinton, which many people have probably heard about. This, Democrats at the time were feeling a lot of pressure to kind of show a harder stance on crime and try to take some of the efforts and voters from Republicans at the time. And so Bill Clinton signed into law the largest crime bill in US history. It expanded who got the death penalty and created new crimes for who got the death penalty. It created this 3 strikes rule in which there was mandatory life imprisonment for a 3rd violent felony. And states really got a lot of money and financial incentives to increase their police force, prison expansion, and new prison construction. Today, we obviously see, and we practice in our ED, a very different culture and treatment of people struggling with drug addiction and substance use disorders. Now, the perception of substance use is that it's a disease that deserves compassion, treatment, medical care. However, that was a very different perception of what drug use was when it was affecting predominantly Black communities in the crack epidemic. The difference here is race. So when heroin started perpetuating white affluent communities in the suburbs, we saw a very different tone take place in response to drug abuse. If you look at the media articles, heroin users are often painted as victims, and there's usually a lot of information about how hard it is on the families. And now we have all these, Suboxone and options for people to get treatment for their substance use disorder. However, Black Americans were not afforded the same empathy and medical treatment when dealing with the crack epidemic in the 80s. And we have a lot of work to still do to undo those disparities. So just to quickly go over some health disparities, that's probably of no surprise to anyone. There is some studies that show that 1 year in prison reduces life expectancy by 2 years. They face a number of chronic health conditions from infectious disease, substance use disorders, mental illness, suicide and violence, and just other chronic physical conditions. When compared to the general population, people who are incarcerated have much poorer health, much higher rates of chronic physical conditions compared to the general public. And compared to the general population, people with a history of incarceration have a much higher chance of getting infectious disease. HIV/AIDS is 2 to 7 times more prevalent, Hep C 8 to 21 times more, tuberculosis 4 times more, and STDs are also very common. Obviously, as we've talked about, mental health and substance use disorders are a significant problem in our prisons. An estimated 68% of people incarcerated in prisons have an active substance use disorder. Women are actually women who are incarcerated, more likely to have mental health disorders. And it tends to mostly be major depressive disorder, bipolar disorder, anxiety disorder, to name a few. So what are we doing to help people inside prisons? So interestingly, incarcerated populations are the only population in the United States that have a constitutional right to adequate medical care. A 1976 Supreme Court case ruled that denying adequate medical care to prisoners was cruel and unusual punishment, violating the 8th Amendment. But what does this mean? So while they have a constitutional right to adequate medical care, there's no federal standards. This varies state to state. It varies by size, jail, prison. There's literally no federal standards for what adequate medical care means. Interestingly, in New York, a 2009 law was passed that required that prison systems care for people with HIV and Hep C in accordance with professional standards. And now we see that people in New York State who have HIV have a lower, the viral suppression rate of people living with HIV in New York prisons is actually better than the general population. There have been some efforts to create, there's been some bills to create other oversights similar to, for other chronic medical conditions, but they have largely failed to go through the state government. Also, the correctional itself is very, hazardous, dangerous for people, probably not surprisingly. And most facilities for their medical care require a copay. So New York State does not, but most of them do. The average cost of a copay for medical care in a prison is $2, which might not seem like much, but prisoners essentially make cents per hour for their labor in prisons and are often really highly taxed. So this means that prisoners are often working hundreds of hours in order to afford the copay for a medical visit. And then, of course, prisons' healthcare systems are usually built around the needs of men, and reproductive healthcare, prenatal care is very much lacking. Also, we have a rapidly aging prison population. The healthcare needs of our elderly people in prisons are definitely not being met. And New York City in particular has a really big problem. So Rikers has a number of problems. All you have to do is search Rikers. I'll go through this quickly. But Rikers has denied medical care at the rate of thousands per month, often being ignored by medical staff. And there's been an alarming number of deaths in Rikers from this neglect. And so just a quick, simple search shows how significant the problem is. Under Mayor Adams, there have been 31 people who have died in Rikers. Khalif Browder was a famous case and person who committed suicide while waiting 3 years for his trial. And then recently, last month, a woman died in Department of Corrections custody. I'm going to skip this, but COVID really highlighted the problem of, or the public health crisis that incarceration puts when you have an infectious disease or other vulnerable conditions in a really overcrowded, under-resourced area. And yeah, so just real quick, incarceration also affects community health. 11.3 million adults, or no, 1,113 million adults have had an immediate family member incarcerated, and they're more likely to experience adverse behavioral health problems and adverse health outcomes. And we just see that, when people leave prison, they really struggle with access to healthcare, access to employment, access to housing, which we all know are social determinants for health outcomes in the long run. Last two slides. So, a new thing that happened in 2023 was that it was announced that people who were being released from prison could apply for Medicaid up to 90 days before their release. Prisoners are not allowed to get health insurance, including Medicaid, but now there was a new law that was created to allow prisoners to be able to apply for Medicaid 90 days before their release, increasing the odds that they would have health insurance coverage by the time they were released. There are a number of other things that we could do as a society better, both on a local and federal level. A few things, a number of things are listed here, but that we kind of talked about, healthy dietary options are a huge thing. Creating standard for all correctional facilities for healthcare and access, reducing copays or making sure that they match kind of equitable measure of what people are making in prison systems, and much more. So just from the ED, my last slide, obviously this is a huge problem, and it might feel like, what can we do about it? So we all got a lecture in our orientation. I don't know if the interns did, but we got a lecture in orientation. Apparently Health and Hospitals has a program to help people who are recently released from prison access medical care, obtain prescriptions, and it's called the PORT program. If you Google the PORT program, there's a number that comes up. I honestly don't know what happens when you call the number, but I have given the number out to a couple people. And supposedly, you know, they have people to help people get into clinics, help with prescriptions, help get insurance, and just help make their transition out of out of prison and into the community a little bit better with more access to medical care. Also, something that's important is the use of Z codes. So Z codes are ICD-10 codes related to social determinants of health. When you discharge someone, I really encourage you to use one of the Z codes related to incarceration. So Z65 is problems related to any psychosocial circumstances. But Z65.0 is specific for conviction in civil and criminal proceedings without imprisonment. So that may be people that come in from the precincts in police custody. Z65.1 is imprisonment and other incarceration. Z65.2 is problems related to release from prison. And Z65.3 is problems related to other legal circumstances. So by using these ICD-9 codes, the city can actually track numbers of the patients that we are seeing dealing with this and hopefully increase funding. There's a number of laws going through the New York State Legislature and on a federal level. A couple are listed here. I'm not going to go into it for time, but I would encourage people to look at the laws locally and on a federal level that are helping reform incarceration. There's also a number of organizations out there, both locally and federally, and you can do your own research, but here are some listed as well. And that's it. So I want to thank the Social EM Lecture Series group, Dr. A, Sklar, Graff, and Gibson. I know that was a big talk, but you know, I hope there's some things to think about when we care for people that come in police custody or from prison.